right, everyone, welcome. We're going to tackle a super high-yield topic for your exams today, amoebic liver abscess. My goal here is to break this down into really clear, super memorable points. This stuff that actually sticks. Let's make this revision session as efficient as we possibly can. Okay, here's the game plan. We'll start with the basics, follow the parasite's nasty little journey, see what it looks like in a patient, figure out how to diagnose it, talk about the fix, and then, of course, a rapid-fire summary at the end. Let's get right into it. All right, section 1, the basics. So what exactly is an amoebic liver abscess and where does it come from? So at its core, an amoebic liver abscess, or ALA, is basically a collection of pus in the liver, but it's not from bacteria. It's caused by this little protozoan parasite, Entamoeba histolytica. Now, the key thing to remember for your exams is this. It's the most common way amoebiasis shows up outside of the gut. The parasite starts in the intestines, right? But when it decides to go on a trip, the liver is its absolute favorite vacation spot. And here's a super easy way to remember the basic cause, the etiology. Just use the name itself, ALA. A is for the agent, that's Entamoeba histolytica. L is for the location. You'll mostly see this in developing countries, especially in the tropics. And the final A is for acquisition. How do you get it? By ingesting food or water that's been contaminated with cysts. So it's that classic fecal-oral route. Super simple, right? Okay, so who is most at risk? Here's another great mnemonic for you. Mimic. M is for males, and this is a huge point, guys. The male-to-female ratio is a staggering 9-to-1. Definitely a key exam fact. I for immigrants from areas where this is common. M for men who have sex with men. I for immunosuppression, makes sense. And finally, C for crowding and poor hygiene. So remember, mimic. Okay, moving on to section 2. Let's talk about how this parasite actually invades the body. Understanding the step-by-step process is so important because a lot of exam questions love to ask about the specific weapons, the virulence factors that this parasite uses. So it all starts with ingestion. You swallow the infective form, which is this really tough quadrinucleated cyst. Think of it like a little armored vehicle. Once the cyst gets to the small intestine, it's like, okay, we've arrived. It undergoes what we call excistation. Basically, the doors open and out come the active moving forms, the trophozoites. Now these trophozoites, they're on a mission. They start multiplying and they need to latch onto the intestinal wall to set up camp. And how do they do that? This is super high yield, you guys, so listen up. They use a key virulence factor called the Gal/Nog-lectin antigen. It's like their molecular grappling hook. Remember that name, Gal/Nog-lectin antigen. But just attaching isn't enough for these guys. Oh no. Once they're latched on, they start releasing these powerful enzymes, things like cysteine proteases, and these enzymes literally start to digest the intestinal wall. It's pretty brutal. This allows them to burrow deep into the tissue, and this is what creates those classic flask-shaped ulcers you hear about with intestinal amoebiasis. And now, for the great escape. To get to the liver, these trophozoites have to get into the bloodstream. They chew through the tissue until they hit a blood vessel, and then boom, they're in the portal circulation. You can think of this as a direct highway leading straight to the liver. And what's really clever, and kind of scary, is that they have ways to fight off our body's own defense system, the complement system, so they can survive the journey. So they arrive at their destination, the liver. Now, why the right lobe most of the time? It's all about blood flow dynamics in the portal vein. Once there, the trophozoites clog up the tiny hepatic venules. This cuts off the oxygen supply to the liver cells, the hepatocytes, and they start to die. That's called anaxic necrosis. The body then tries to contain this mass by building a wall around all that dead tissue, and that, my friends, is your abscess. Okay, section 3, the clinical picture. So we know how it happens, but what does it actually look like in a patient? Knowing these signs and symptoms is absolutely key for spotting this in your clinical vignette questions. And yep, you guessed it, we've got another mnemonic for you, fever. F is for fever. This is probably the most consistent thing you'll see. E is for epigastric pain and tender hepatomegaly, meaning a big, painful liver. V is for very rare jaundice. This is a bit of a trick, right? It's a liver problem, but jaundice isn't common. E is for extreme weakness and weight loss. And finally, R for right upper quadrant pain. So remember fever, especially that fever and tender liver combo. And here we have it. This is probably the most classic buzzwordy finding you'll ever see for this condition. If you stick a needle in that abscess and draw out the fluid, you get this. Anchovy sauce pus. I know, it's gross, but you'll never forget it. It looks just like its name. Thick, chocolate brown, and it's actually odorless. And here's the crucial part for your exams. It's not actually pus. It's made of dead liver cells, necrotic hepatocytes, not neutrophils. That's a huge difference from a bacterial abscess. Now, what happens if you don't treat this? Well, it's not good. The abscess can keep growing until it bursts, and that can lead to some really serious, life-threatening complications. Where it ruptures determines what happens next. The most common scenario, it ruptures upwards, into the right pleural space around the lung. But it can also go down into the peritoneum or straight into the lungs, or if it's an abscess in the left lobe of the liver, it can even rupture into the pericardium, the sac around the heart. All very bad news. All right, section 4, confirming the diagnosis. This is a huge area for exam questions, so let's really focus in on how we prove what's going on. Okay, so this is a nice little summary of all the tools we have in our diagnostic arsenal. Let's dig into the details of each one. Okay, let's break this table down because it's packed with high-yield info. First off, what's the absolute best test, the gold standard? That's going to be PCR on the pus from the abscess. It has nearly 100% sensitivity and specificity. Can't beat it. Now, what if you can't get pus? The most useful blood test, or serology, is antibody detection using ELISA. It's highly sensitive, around 90%. Now, let's talk about the big exam trap, stool microscopy. You might think, oh, it's a gut parasite. Let's check the stool. Nope. For an amoebic liver abscess, stool microscopy is pretty much useless. Why? Because the active infection is in the liver, not necessarily in the gut anymore. Please remember that pitfall. Section 5, the solution. So we've got our diagnosis. Now what? How do we treat this? Well, the strategy is a really important two-pronged attack. We have to hit it from two different angles to make sure it's gone for good. And this diagram shows that protocol perfectly. You can't just use one type of drug. You need two different kinds of agents to really knock out the infection and stop it from coming back. So here's how it works. Step 1, you use what's called a tissue agent, like metronidazole. This drug goes after the invasive trophozoites that are causing all the trouble in the liver. That's what resolves the abscess. But you can't stop there. And this is key. Step 2, you have to follow up with a luminal agent, something like iodoquinol or paramycin. This second drug's job is to mop up any cysts that are still hanging out in the intestines. If you skip this step, the patient can relapse. So it's tissue agent first, then luminal agent. Always. And of course, we have to talk about prevention, because prevention is always better than cure. At the end of the day, this is a disease of poor sanitation. And there's a great acronym to remember the prevention plan. WASH. W for clean, safe water. A for avoiding contaminated food. S for proper sanitation and latrines. And H for good personal hygiene. It's that simple, but so incredibly important. All right, we're at the finish line. Section 6, the summary. Let's do a quick recap. Seriously, if you're short on time and can only remember one thing, make it what's on this next slide. This is your ultimate cheat sheet for the exam. Okay, this is your screenshot moment for sure. This little box has everything. The agent, Entamoeba histolytica. The journey, gut to portal vein to the right lobe of the liver. The classic sign, that unforgettable anchovy sauce pus. Key symptoms, fever and a tender, big liver. Diagnosis, gold standard is PCR on the pus, but for blood tests, antibody ELISA is your go-to. And the treatment? Remember, it's that two-step process. Metronidazole first for the tissue, then a luminal agent like iodoquinol, and finally that critical exam pitfall. Stool microscopy is not useful for diagnosing ALA. Now these points down and you are going to be in fantastic shape. Good luck with your studies.